Greetings, everyone. My name is C.B. Mamaril, and on behalf of the Systems for Action National Coordinating Center, I'd like to welcome all of you to today's Systems for Action Research and Progress webinar on strategies to achieve alignment, collaboration, and synergy across delivery and financing systems. Before we get started, we would like to first acknowledge the funding and support of the Robert Wood Johnson Foundation. Systems for Action is a national program office of the Robert Wood Johnson Foundation and collaborative effort of the Center for Public Health Systems and Services Research in the College of Public Health and the Center for Poverty Research in the Gatton College of Business and Economics, administered by the University of Kentucky. We are excited to have with us today a study team that is part of our second cohort of S4A research grantees, who will be presenting a topic on linking education and health data to improve adolescent health in Los Angeles. And so I'd like to take the next few minutes to introduce the principal investigators of the study team and also the commentators for today's webinar. So I'd like to first start off by introducing to you Dr. Sheryl Kataoka, who is a professor in the UCLA Division of Child and Adolescent Psychiatry, where she serves as a training director of Child and Adolescent Psychiatry Fellowship. She has been collaborating with the schools and districts in Los Angeles and across the country for over 18 years. As a child psychiatrist and health services researcher, Dr. Kataoka has been investigating methods of delivering evidence-based mental health services in schools. Her research has led to a greater understanding of the role of schools in decreasing disparities in mental health care for ethnic minority children and their families, and she has examined the effects of mental health services on academic outcomes. Our speaker for today who will be presenting the research for their team is Dr. Rebecca Dudovitz, who is a pediatrician and health services researcher at UCLA. Following her pediatric residency training, she completed a health services research fellowship through the Robert Wood Johnson Clinical Scholars Program. Her research interests includes understanding the link between academic achievement and health and identifying ways for education and health providers to work together to reduce disparities. Dr. Dudovitz has been collaborating with the Los Angeles Unified School District and the Los Angeles Trust for Children's Health since 2012. Our first commentator for today's webinar will be Mary Jane Puffer, who is Executive Director of the LA Trust for Children's Health. Her role at the LA Trust represents the nexus of all she has been committed to throughout her career as a pediatric nurse, a community health program director, and lead developer of health programs. In her role as Executive Director, she helps to facilitate the development of LA Unified School District's wellness networks and is on the cutting edge in developing community prevention framework strategies for health programming in schools. Mary Jane is a 35-year veteran in healthcare and program development. She has successfully developed and managed both international and domestic health programs, and she also serves on the State Adolescent Sexual Health Work Group, the School Health Coalition of Los Angeles County, the Los Angeles School Health Policy Roundtable, and the Los Angeles Preconception Health Collaborative. She's also co-chair of the California Preconception Healthcare Council and a teen pregnancy prevention advisory board member for the Fresno Regional Foundation. Our other commentator for today is Joshua Kaufman, who is a coordinator with the Los Angeles Unified School District School Mental Health, currently administering the SMH school education program that provides educationally related intensive counseling services to students in need of intensive counseling through their individualized education program. Joshua's past professional efforts have largely been focused on the implementation and dissemination of evidence-based, trauma-informed, and trauma-specific practice models and the provision of clinical consultation training both within LAUSD as well as nationally. He has provided trainings on response and emergency management for schools, school-based screening and assessment, trauma awareness, trauma-informed schools, psychological first aid, and cognitive behavioral intervention for trauma in schools, which is a nationally recognized evidence-based treatment model for the U.S. And so with that, I'd like to turn it over to you, Rebecca.
Great. Thank you so much. I just wanted to start by thanking everyone for taking the time to attend and learn about our study, and to say that I'm here on behalf of our larger study team, which is the folks pictured and listed here. And they bring a wealth of knowledge and experience to the project, so I will do my very best to represent them well today. And I also wanted to thank both Joshua and Mary Jane for joining us today and providing really their on-the-ground perspective of how this project hopefully will support the work that they're doing to improve the health of children and adolescents in Los Angeles. So this project is really grounded in the wealth of research and data showing a robust and consistent relationship between school performance and behavioral health outcomes, which we generally define as mental health and substance use. I'm going to start just by giving you a snapshot of the literature in this area. So first, academic performance has been consistently related to substance use. This association is incredibly robust across time, region, demographics, and has been shown with a whole variety of school performance measures. So some examples are listed here, and they include grades and standardized test scores, high school graduation, grade retention, meaning being held back in a grade, and educational attainment. So one example shown here is from a study that we published with Mitch Wong on a cross-sectional sample of about 1,000 low-income minority students in Los Angeles. And you can see here that students with a grade point average of B or of a B- and above had lower rates of all 5 forms of substance use compared to students earning a C+ or lower. And this relationship holds even after controlling for demographics, school characteristics, and parenting style, as you see in this sort of staged regression models here. This same paper also looked at standardized test scores rather than grades as a measure of academic performance and found pretty much similar results. And although the previous example used a dichotomous measure of school performance as sort of the main predictor, when we look at categorical or continuous measures, you see a very similar dose-response relationship. This data is actually from the CDC's Youth Risk Behavior Survey and shows how rates of substance use and a variety of other unhealthy behaviors increase as self-reported grades decrease. And then with regards to mental health outcomes, studies show that grades and attendance are consistently negatively associated with depression. So this here is a study of middle school students in Los Angeles and demonstrates this relationship. You can see highlighted in the red box that both GPA and absenteeism are both associated with depression here. And then similarly, academic achievement is associated with PTSD or post-traumatic stress disorder. This is a study of African American middle school students in Chicago and shows that achievement, which was measured by standardized tests here, is associated with PTSD. So you can see that in this first column here, the association is fairly strong. And then another marker of school performance is suspensions or expulsions. And this is data from a cross-sectional survey conducted with over 28,000 sixth graders in LAUSD. And you can see here that greater involvement in violence is associated with the higher odds of suspensions among both boys and girls in the red box. So it's clear from the previous work that's been done that school performance is highly correlated with behavioral health issues. And the relationship between school performance and behavioral health is likely bidirectional, where poor school performance might contribute to greater behavioral health needs as kids start hanging out with other kids who are doing poorly in school and, for example, engaging in more substance use. And vice versa, those behavioral health disorders are also impacting academic achievement. But regardless of the direction of this association, really as long as school performance and behavioral health issues track together, then we could use this fact and use that academic data to help us identify students who have behavioral health needs so that we can ultimately get them into services. To do that, though, we need to know which measure of academic performance is the most useful, or which combination of measures. So is it grades? Is it attendance? Is it suspensions? If it is grades, is it the actual GPA or grade point average? Is it the number of D's or F's? Is it the number of A's? We don't know the answer to these questions. And then for whom? Do we need different measures depending on the population? So for example, do some academic indicators work better to identify kids with behavioral health needs in schools where the population is very high risk versus a lower risk school population? What about low-income minority kids versus middle-income white kids? Do the same measures work just as well in those populations, or at low-performing versus high-performing schools? And then there's the issue of timing. Is it more useful to look at cross-sectional data or longitudinal measures of school performance? For example, maybe it's not an absolute threshold in attendance or school performance that might alert you to the fact that a child has a behavioral health need. Maybe it's really if an A student starts earning B's and C's, that's a red flag, and it's the change from prior performance that's most meaningful. All of these are really important questions, and they have not been answered in other studies. So ultimately, our goal is to test whether this type of strategy of using academic data to identify behavioral health needs could be better, at least at the population level, than just using typical clinical screening tools that we already have to identify behavioral health needs. And we think this very well may be the case, and that's because this strategy relies on this wealth of academic data that is automatically collected on nearly every child. So as a result, as a population health management tool, it does not rely on families making it into a clinic or a school that has the resources to do universal screening for these multiple behavioral health issues. And that's really helpful because the existing barriers to seeking behavioral health services disproportionately impact disadvantaged communities. So we hope that this strategy might be used to circumvent some of those barriers. Also, there's the concern that by the time a family brings a child into clinic for a behavioral health need, that problem might already be quite significant. And if we could identify and address those health needs earlier, we might be able to address them more easily, more successfully, and avoid negative impacts on students' academic performance. Again, kind of harnessing this relationship between poor school performance and behavioral health. So ultimately, this project seeks to really determine which aspects of school performance are the most sensitive and specific indicators of behavioral health needs, and develop a tool that's feasible and useful in diverse communities. Because it's not helpful if we end up seeing that this tool just flags all low-income minority students. We want a tool that can be useful in many different student populations. So our aims were to develop a risk indicator tool using academic data to identify students at high risk for PTSD, depression, and substance use, and then to test the sensitivity, specificity, and predictive value of the tool to identify each behavioral health outcome in a variety of data sets. This is an overview of our approach. First, we wanted to make sure that the variables and outcomes we selected were really relevant to those on the ground in Los Angeles who are trying to identify and address behavioral health needs for students. So for that, we turned to our community partners in the Los Angeles Unified School District's Office of School Mental Health and the LA Trust for Children's Health. And I will tell you a little bit more about them and their invaluable feedback on the next few slides. Second, we wanted to create and test a tool that would be both nationally and locally relevant. So we sought to use data sets that reflected both populations. As a result, this project is being done using 5 different data sets, and I will tell you more about them as well as we move through the presentation. So just to give you an overview of our local context, Sheryl and I both work closely with the Los Angeles Unified School District, which you may know is the 2nd largest district in the nation and the largest provider of free and reduced price meals. As you can see, the majority of students are Latino, 90% are non-white, and there's a very high concentration of children in poverty, which is represented by the fact that 84% qualify for free or reduced price meals. The good news is that in this very vulnerable population, school mental health is incredibly active in caring for this high-risk group of kids. They conduct mental health screenings in a variety of settings, provide on-campus mental health services, as well as referrals and linkage to off-campus services. And more recently, they've focused quite intentionally on identifying students exposed to trauma and facilitating programs and services that build resilience. So this has become a really important focus as the district moves towards being a fully trauma-informed system. The LA Trust for Children's Health is a nonprofit foundation that supports academic success by improving the health of students of the Los Angeles Unified School District. And they were started in 1991 and are really the driving force behind health and wellness programs at LAUSD. One of their key roles has been to establish and support 15 wellness centers, which are school-based health centers that are designed to provide integrated, comprehensive physical, mental, and oral health care services for students, their families, and the community. And they also serve to advocate for health policy change at the school district and beyond. So when we talked about this project with our partners at School Mental Health and the LA Trust, they had some really important insights which informed our work. Firstly, they were very positive about the idea of focusing on routinely collected information that would essentially require minimal investment from the district to apply this risk prediction tool to their student population. They felt that it would be important to focus on depression, substance use, and PTSD, as these are common conditions where treatment can really have a positive impact on outcomes, and where schools really recognize that these behavioral health conditions are having a negative impact on their students' performance. They were really interested in particular in finding better ways to identify kids with PTSD among those exposed to trauma, in part because trauma exposure is so prevalent in many of these high-risk schools. The other thing they cautioned us about was the difficulty in relying on school disciplinary data as a marker for school behavior issues. And this is because LAUSD has been moving away from a punitive model for school discipline, which is consistent with a lot of the work that's happening across the nation, and moving towards more of a restorative justice approach. So hence they've largely eliminated out-of-school suspensions in the district. And there's no clear consensus on whether or how disciplinary actions are recorded, so there's lots of variation across schools that may or may not correlate with what's actually happening on the ground. So generally the thought was that this would not be a great reliable measure for inclusion in a locally relevant prediction model. And actually just one more note on the previous slide. The last thing that they told us was that there would be a need for both population health management at the individual student level, which is what we initially set out to address, as well as identifying students with behavioral, which would work to identify students with behavioral health needs. But they also pointed out that a model to help manage resources at the district level by identifying schools with the highest level of behavioral health needs would also be really valuable. And so that got us thinking about the potential for this kind of approach to work both at the individual and school level. Okay, so with that backdrop, we started diving into the data to start constructing these models. And as I said earlier, we're using a variety of data sets, which I'll take you through in the next few slides. For all of this work, we needed data sets that included both academic and behavioral health outcomes. So first, we're using AdHealth, or the National Longitudinal Study of Adolescent to Adult Health. This has the advantage of being a large, nationally representative sample, but unfortunately it does not include measures of PTSD, so this makes it less locally relevant for us. The second data set we're using is Rise Up, which is a smaller local sample, but contains data for all three outcomes of interest. And although Rise Up participants look very representative of other students in LAUSD, this was a charter school study, and so all students in the study applied to a high-performing charter school at some point. and about half the sample actually attended a charter school, and the other half ended up in public schools. So there may still be some important differences between this sample and the average LAUSD student. So hence, we'll be testing the models developed in the first two samples on 3 different samples from actual LAUSD students to see how well this tool might function in the real world. So to give you a little bit of background regarding AdHealth, this is a school-based sample that originally included 80 high schools and 52 feeder schools. We're using the first 2 waves of data, which were collected over 2 consecutive years in the mid-1990s. And then during the wave 3 data collection time point, they received high school transcripts on about 10,000 participants. In addition to this transcript data that reports students' grades and coursework, we also have self-reported attendance, truancy, suspensions, and expulsions for their academic data measures. For our outcomes, we have self-reported substance use, which we've defined as 30-day alcohol, marijuana, and other drug use, and problem alcohol use, which is really a series of items that asks about life problems related to substance use and symptoms of physical addiction, and those items mirror the diagnostic criteria for a substance use disorder. Respondents also completed the CESD depression questionnaire, which is a commonly used screening tool for depression symptoms. And as mentioned before, AdHealth does not include measures of PTSD. In terms of demographics, we wanted to use things that would be routinely available in a child's academic school record. So those are things like grade, age, gender, race, ethnicity, and whether the student qualifies for free or reduced price lunch, which, as I mentioned before, is a measure of poverty. So here's a brief snapshot of our analytic sample and some weighted descriptive statistics. You can see that as a nationally representative sample, the majority of students are white, and the average household income is just under $50,000 a year. There were relatively high rates of substance use and depression, which are consistent with other national estimates. So you can see that 21% were positive for a diagnosis of alcohol misuse or alcohol use disorder. You can see that 13% reported using marijuana, 6% reported other drug use, 17% screened positive for depression. Moving on to the Rise Up study, as I mentioned, this is data from a natural experiment using admissions lotteries for high-performing charter schools in Los Angeles to study the impact of school environments on adolescent health. The sample is comprised of students in Los Angeles who applied to one of 5 high-performing charter schools that served largely low-income minority students. Students applied for admission into the 9th grade during the 2013 or 2014 school years. About half the kids got into the charter school through the lottery and half did not. So overall, 1,270 students were enrolled and completed surveys at 3 time points. The first was during the transition to high school, so at the end of 8th grade or beginning of 9th grade. The second was at the end of 10th grade, and then the final wave is at the end of 11th grade. In addition, high school transcripts were requested and have been obtained for nearly all participants. At each survey wave, students reported the frequency of alcohol, marijuana, and other drug use in the last 30 days, and completed a measure of alcohol misuse and one of marijuana misuse that again mirror those diagnostic criteria of a substance use disorder. They also completed the CESD depression scale, and in this case, they did complete the primary care PTSD screener. We also have their grades and coursework from their high school transcripts and their self-reported truancy, as well as whether they switched high schools at each time point. From the baseline survey, we have their age, gender, race, ethnicity, and unfortunately, essentially the entire sample qualified for free and reduced lunch, so measures of socioeconomic status are not likely to be very helpful here. But this is quite representative of LAUSD, as you saw before. So here's a quick snapshot of the Rise Up sample. Although all of these participants applied to a charter school, you can see the sample looks very similar to our overall LAUSD demographics. These are largely second-generation Latino students whose parents are full-time working immigrants. As opposed to the AdHealth sample, they also have a much higher burden of disease. So 38% screened positive for depression, 40% met the cutoff for PTSD, and 30 to 40% for alcohol or marijuana misuse. So we plan to build separate models for each behavioral health outcome in both the AdHealth and RiseUp data sets. For AdHealth, because it's a large data set, we will use a split sample. So we'll develop the model on half the sample and validate it on the other half. For RiseUp, we will develop the model in RiseUp and then validate it in 3 different LAUSD data sets, each focused on a different outcome. We plan to use forward selection to build the models, and we'll retain variables that increase the area under the ROC curve. As we discussed before, we'll explore both absolute values of the academic indicators and the change from the previous year. For the RiseUp model, as I mentioned, we plan to test it in 3 different data sets, and each data set is a sample of LAUSD students and focuses on a different outcome. For substance use, we'll use data from a small randomized trial of a college preparatory program that LAUSD uses called AVID. The AVID trial is testing whether exposure to the program impacts risky health behaviors like substance use. So we have data regarding alcohol and marijuana misuse for currently 240 students, and we'll be linking that data with academic data from the district. We also have data from 260 students who are screened for depression when visiting a school-based health center that we will also be linking with academic data. And then finally, a large number of students were screened for PTSD as part of a school-based resilience classroom curriculum, and this data is already linked to academic performance data. And you can see why LAUSD is so focused on treatment for PTSD, because in that data set, about a quarter of students screened positive for PTSD. So we're moving through the process of data approval, merging, cleaning, and analysis for each of these independent data sets. And you can see here that we're currently developing our models in AdHealth and are just about ready to start doing so with RiseUp. And in the meantime, we're preparing our LAUSD validation data sets, so they'll be ready to go when we're ready to validate that model. So we expect to have the AdHealth model developed and validated by the end of the summer, and are currently wrapping up the process of merging the academic and health data with RiseUp. We anticipate developing that model in August with validation in September. And we will then focus on writing up the results for publication, and also, really importantly, for presentation to stakeholders within the district. Moving forward, we hope to pilot test the tool that we develop with LAUSD at some of the schools that have wellness centers to study its sensitivity and specificity in a real-world setting, and to see if it can help identify students who need additional screening and linkage to behavioral health services. We're also exploring opportunities with other districts to test its applicability beyond LAUSD. And in response to feedback from our community partners, are planning to see if we can develop a school-level tool that might identify schools that are likely to have a high burden of behavioral health needs, so that can better inform how the district allocates resources. We think there are a ton of potential applications for a tool like this, and hope that this is really just the first step in getting to our ultimate goal of being able to use school data as an automatic universal screening tool for behavioral health risks. This would really align the health and education systems for the purpose of population health management, with the ultimate goal of improving both academic and health outcomes. So that is our big dream, and we are hoping to take the first exciting steps here. So with that,
Thank you, Rebecca. Sorry, go ahead.
Go ahead. I was just I was taking over your role here. Go ahead.
No problem, no problem. So thank you, Rebecca. And you know, we just want to encourage everyone who's on the webinar that if you have any questions for Rebecca, or even for later for our commentators, please do type in your questions in the chat box. And so again, we encourage everyone to just type in your questions, and we'll try to get them to at the end of the webinar. So with that, Rebecca, thank you so much. I'd like to turn it over to our first commentator, Mary Jane Puffer.
Hi, can you hear me?
You're coming out loud and clear.
Okay, perfect. Anyway, I just want to say that I am really appreciative of this work We've been working closely with UCLA and school mental health and student health and human services inside of LAUSD to look at how do we get at issues and concerns for students through health and wellness programs, and how do we best ensure that there's an early intervention. So the concept of developing a screening tool or a tool that can be used effectively without a lot of burden on staff inside of the district or providers externally is really critical, I think, at this time. We also have looked in depth with LAUSD at their data around dropout rates, and the idea that within the district, it's like kindergarten attendance, 6th grade dropout, and 9th grade dropout. So these transitional periods are really important. So we've been basically, banging the drum saying it would be really important if there became a systematic way to assess students, particularly at critical points where there are transitions. So the concept of a screening tool that just was routinized for adolescents in the district would be completely invaluable. So we are very supportive, and actually this afternoon we are launching a data set called the Data Exchange that looks at the clinical care delivery, so for asthma, depression screening, substance abuse from the provider angle. The data provided by wellness centers, we want to be able to target our resources more efficiently. So if we know that there's a high level of depression or substance use or asthma, for instance, at a site, that data can really help direct and target resources to highest need areas within the county. So I'm super supportive and very excited about this project. So thank you.
Thank you, Mary Jane. And I'd like to turn it over now to you, Joshua.
Wonderful. Well, first I want to say thank you to the organizers for inviting us to participate and provide a little bit of commentary and feedback. I also want to say that from a school mental health standpoint, it's been invaluable over the last 18 or 20 years to be working with our community research partners. We've transformed tremendously along the way. We still have a long way to go, but we wouldn't be anywhere near where we are in terms of moving the district in the direction we'd like to go in without the ongoing collaborative partnership that we've developed. So the other thing I'd like to say is over the years, we've, within schools, really struggled with the holy grail of school mental health, which is connecting mental health outcomes and academic outcomes and being able to demonstrate that on the ground. There's always a correlation, there's always a connection, but it's been challenging, I think, because of some of the data is measured on a yearly basis, and intervention doesn't always allow for a clear, direct correlation. The other thing that really stood out to me was this idea that we might be able to identify very specific academic indicators to help us with our screening and identification towards service delivery. Excuse me. Over the years, as we've worked with schools, we've partnered around using the data that was available to us. Those students that were scoring below and far below basic on standardized tests, those students with X number of referrals to the dean's office in a given month, those students whose attendance was below what was considered to be a reasonable level. But we never quite have known what the specific measure might be and how that might look different from one school to another. And that, from the standpoint of working smarter, not harder, could really help us with our targeted screening efforts, particularly when we may not have the resources at an individual school to screen universally. So from the standpoint of being able to identify those students who most in need of services, one way we've historically done that was looking at some of these academic and behavioral indicators. The other way was through referral. And of course, the challenge with referral is the students that tend to catch the school or the teacher's eye tend to be those that are externalizing, those that have behaviors that are disruptive, but they don't tend to capture or identify or see the kids in the back of the room that are checked out, that are not doing well academically, but are also not raising any significant red flags. So the more that we can go beyond visible need for referral to look at some of these indicators, I think, the better. And then, of course, as Mary Jane said, from a system and resource standpoint, the exciting thing here is the way that looking at population-based data, looking at school-level information around prevalence or risk could do wonders for and go far in advocacy for additional funding for mental health provision, mental health providers at school sites. As we move forward, as more and more tragedies are occurring in our schools, the call for increased access to psychiatric social workers, increased access to mental health support goes up. And this data and this kind of population level data within school systems could really strengthen the case for adding additional resources and being able to target them appropriately. So I look forward to continue to working with our partners. I look forward to being able to give our on-the-ground school social workers good indicators that they can rely on, whether they're in elementary, middle, or high school, and depending on the student population that they're working with. And I look forward to, as Mary Jane was saying, this idea that we might be able to universally be screening on the back end, and that it could become just a part of practice, much as our school profile work has become within LAUSD in being able to identify what the need is. And the last thing I'll say is the more that we have this information, the more we're able to target the interventions that we're providing. And the more that we're able to help kids re-engage in the educational process, which at the end of the day is our ultimate goal as a district, is all kids able to graduate college or career ready. So this is really exciting. Thanks so much. And my apologies about my voice, which has been threatening to leave me all week.
No worries, Joshua. Thank you so much. Joshua, thank you so much, Mary Jane. Before I turn it back to Rebecca for her response to the comment, again, I'd like to encourage everyone to, if you have any questions about the presentation or even to our commentators, please do type them in the chat box, and we'll try to get to them at the end of this webinar. And so with that, Rebecca, I'd just like to turn it back to you. And so if you have any responses to comments or add any additional ideas or insights that you may have regarding your research and your work.
Thank you. I really appreciate both of the commentators' perspectives, and their work is really what inspired us to take on this project to begin with. I think that concept of working smarter, not harder, is exactly what we're trying to give you the tools to do. And you're absolutely right that both Mary Jane and Joshua talked about the intense work that's happening already and really exciting work that's happening already. But the work sort of relies on our traditional strategies of screening and referral and then getting that kid into services. And I think, that strategy works for some proportion of kids, but there are kids who are invisible and aren't getting identified and aren't making it to services, both because of resource limitations, but also because, of that invisibility factor that Joshua spoke to, that sometimes it's kids who are really acting out that get those referrals and not the kid who, might be depressed and really internalizing all of those symptoms. So, that is our goal, and we are really excited to work with both of these partners moving forward.
I do notice that you did have a slide at the end. Is that something that you wanted to talk a little more about, or was that
Oh,
just
no,
put there?
that's okay. That's just a backup in case someone has a question about it.
Okay, excellent. I think that's a good segue. So we can just put up that slide for now. Was there anything else more you wanted to add, or before we turn it over to the audience for their questions?
No, I would love to take questions if there are some from the audience.
All right, so we have actually a lot of time, so we do again encourage everyone to, if you have any questions for the presenters or the commentators, please do type them in and we'll get to them. I guess just to start the ball rolling, I can probably bring up some of the stuff that you brought up in the earlier slides. One would be this slide, I think, here about the bidirectionality. So right now, I guess, what's the status quo in terms of what, the LAUSD has been doing in terms of screening? Is there anything in place right now that they do? Because I know this predictive tool is sort of to help them into the future, but currently what's sort of the system, I guess in summary, what's happening right now on the ground?
Yeah, maybe Joshua, do you want to talk about that?
Yeah, I'd be happy to. So school mental health currently has four big programs that we run. One of them is our school-based program in which schools purchase psychiatric social work time to provide basically school social work, school-based psychiatric social work. And in that context, we offer multi-tiered systems of support that begins with universal classroom resilience building interventions. And some of the data actually that was used in the study comes out of a resilience check-in questionnaire that we use at the beginning and end of this classroom-based intervention, primarily being utilized in the 9th grade, but also in middle school as well. Those students who are in need of additional support, we have a secondary, more involved tool that actually requires parental consent that sort of combines measures like the child PTSD symptom scale, like the PHQ 2 and 9, like the GADS 2 and 7, the CRAFT, and the Columbia Suicide Severity Rating Scale. That instrument is often very helpful in identifying those students beyond the classroom-based intervention that are in need of more targeted services such as CBITS or a referral to one of our outpatient mental health clinics. Within our clinics, as county mental health providers, we use the county-approved tools per symptom area. And then, within our special ed counseling program that I currently administer, we've also been using the wellness checkup questionnaire universally with all of our students. And one of the things that's been so helpful about using a measure like that is all of a sudden we are able to target the services that we're providing to address the specific symptomatology that's getting in the way of kids' ability to access the curriculum. And what we're seeing over the last couple of years for the very first time is that we're able to be exiting students from these intensive counseling services, reducing the amount of time that they're needing to be pulled from class for mental health support and improving their ability to access the curriculum. So, as far as universal measures, there are a lot of great free measures out there. If you go to the Center for School Mental Health out of the University of Maryland, on the resources for clinicians list, there's a whole list of free assessments that clinicians and school districts can pull from But again, within the district, working with our research partners over the years, we've been able to develop some comprehensive tools that have been really helpful in our being able to understand and address the needs of students that we are able to support. And of course, for those students that don't come through the classroom-based intervention, we do have schools in which there's simply targeted screening also. Really depends on resources and clinician availability, however.
All right, Joshua, that's great. Does that answer the question that Carrie had about, asking about specific tests and assessments that are used to gauge behavioral and emotional problems with the children? So that's excellent. So now all the questions are pouring in, so let's get to them. The first one's from Jimmy. Has using the school site student assistance team as a venue to become more familiar with student behavior and avenues for intervention. I guess I'd speak a little more to that, I guess. The question's a little half paraphrase, but go ahead.
Joshua, do you have
anyone?
A sense of that?
Over the years within LAUSD, there has been a coordination of services team model that's been used that historically was really focused on learning supports, really looking at some of the work coming out of the UCLA Center for School Mental Health. More recently, though, that student assistance team has broadened out to also look at academic concerns. And again, that's invaluable in being able to collaborate, to work together, to make sure that services are not being duplicated, and to identify who the primary sort of case carrier, if you will, would be for any student, regardless of their need. The challenge, though, again, with models like this is that they require students to first be identified before they can be referred to the student assistance team or the coordination of services team. And what we miss are those that are suffering in silence. And I think that's the value of using academic indicators to be able to at least know who we need to pay more attention to from a behavioral health standpoint.
We have questions.
Mary, do you want to talk about the Wellness Coordinating Council and like the team meetings that happen at school sites with wellness centers?
Yeah, so the wellness center model that we have, and actually we call them wellness centers and differentiate them from school-based health centers because the wellness centers are actually full-service primary care clinics on campuses in the highest need spots in Los Angeles, and they also serve community and family. But each one of these 15 campuses has a wellness coordinating council that is focused on best practices for referral and systems integration. And each site has a student advisory board that works on, prevention campaigns, et cetera. But with the wellness coordinating councils, they're really pushing best practices. So how do we make sure that referrals are enacted and completed? And they're really focused on that movement. But the idea also, as Josh said, there are teachers and after-school program delivery service providers who, really are in a position to catch children early. So, like, the concept of this type of tool, as Josh pointed out and Rebecca talked about, the student who is suffering in silence, the one that is not a disruptive child in class but actually has quite a bit of trauma, for teachers and after-school providers to be able to absolutely know that there is a way that they could support a child earlier. We found that to be overwhelmingly positive with other staff. And just another caution is that if we start a system like this and want to pilot it right away, which I would love to do, we need to understand what it will take to have appropriate response in place for what might be discovered. And school mental health does a great job, but also how other systems might need to be enacted, like what needs to happen for wellness, coordinating counsel staff. If children just need, an extra set of support, their family might need legal counsel. So this opens up it opens up like the question of what is the plethora of what is going to be required to make sure our kids are successful, and how do we expand and build on those partnerships. So really looking at this as a identifier, but then B, systems development opportunity for expanded partnerships and more integrated services is really a key question and issue, and an important function of what this type of screening can help us do for children's health and wellness.
And I think that raises an important point, Mary Jane, and it's a question that goes to from James, who asks, what are envisioned as informed consent framework for students and parents for the screening practices and, the treatment and referral practices? What would be the informed consent framework for that, or what would be envisioned for that?
Yeah, I think that's an excellent point and something that we're always thinking about, as you know, both in terms of our HIPAA, our patient protection requirements, as well as FERPA, which protects academic data, and the privacy requirements in both spheres are pretty much constantly on our minds. One of the things that Joshua mentioned is that actually some of this is sort of happening already. PSA counselors or attendance counselors, for example, are looking at the kids who have missed a certain threshold of school days and calling them in and trying to figure out what's going on. Already, school mental health providers are asking the principals and assistant principals, like, who's been coming to your office, who's getting in trouble, and teachers are already kind of doing this as well. But right now it's happening without a defined set of risk factors, of academic risk factors, because we just don't know what the best predictor of behavioral health needs are. So, one vision would be to have a system that was completely contained within the school district and for whom, folks already have access to that academic data as part of being in the district. Another system, as Mary Jane alluded to, might need to draw on external supports. And in that case, there would need to be a well-defined process for gathering parent consent to share that information that a child needs a referral service. It's not necessarily true that the provider of behavioral health needs to see the child's academic data. They just need to know that the child screened positive for a behavioral health need, really. Now, to sort of take this another step further, so that's really focused on sort of a school environment and how a school might use this tool, which is how we initially approached the project. But if you extend this thinking beyond into the larger healthcare system, I think ultimately there may be potential for a pediatric provider. For example, I'm a primary care provider. I would love to know, of the kids in my panel, who screens positive based on their academic performance that I need to call into my clinic for screening. Who should I be reaching out to intentionally and say, hey, you need to come in and we need to do a depression screener on you. The constructing a system that would really allow that communication between the education and the healthcare sectors, that doesn't exist at this point, and it would definitely require active parental consent to participate in a system like that, according to our current laws.
Rebecca, can I add a little bit there?
Yeah.
At the school site level, when it comes to some of the screening and data collection instruments that we're using, the question around informed consent really falls along the line of if we are asking about psychiatric symptomatology. And so, for example, the resilience check-in, the RCI that we use, is primarily focused on resilience skills, on sense of belonging, on a lot of the child's experience of being on campus. And for that's not necessarily something that requires parental consent. But as soon as we identify that there is a student who is in need of additional support or screening, that's where the consenting process comes in terms of the more intensive screening procedures that we have. And then, at a sort of school level, and particularly schools that have co-located clinics on site, there are ways that those systems can partner around sort of including consenting paperwork in the annual enrollment and re-enrollment information, so that every child's family has an opportunity to decide whether or not they would like for there to be able to be communication between the school and either medical or mental health clinic co-located on campus. Certainly when I was working in the school that in which we were able to be universally screening for symptoms of child traumatic stress, there also happened to be a community health clinic on site, and there was documentation in the enrollment paperwork specifically around students being able to access services such as examinations for sports and et cetera. So, at that larger systemic level, that would be an incredible memorandum of understanding between health systems and education systems. There have been similar memoranda of understanding developed to address significant crises and threat in towns, municipalities around the country and internationally when it comes to looking at partnership between the county offices of mental health and education systems. So I think that would be a really exciting direction to go in. But again, we would have to move really slowly on something like that to assure that there wasn't a perception of sort of overreach, which I think we're in the age of needing to really pay attention to overreach in terms of public perception. So.
Well, we got time for 2 more questions, which I have here on queue. I guess you answered the question from Barbara about the filters for overall confidentiality and protection of families, but she does want clarification, Rebecca, on the Rise Up model. Was it only geared towards charter school participants rather than public school participants, or was it utilized for both?
Oh, great question. Although all participants in that sample applied to a charter school, only about half actually attended a charter school, and the other half ended up in LAUSD schools. So we do think that the model that we develop in that sample would apply to a general public school population, but again, are planning to test that with those 3 actual LAUSD samples to make sure that that's the case.
And the final question from Desiree. I think you alluded to this a little bit a while ago about linkages. How are hospital health systems changing the way they see patients? Are they receiving absenteeism and school performance data and changing their delivery of care? What training do you provide healthcare providers? So just, I guess, some final thoughts on those linkages between the schools and a healthcare system?
Yeah, as I said, as a primary care provider, I think this would be an incredible shift in how we think about population health. I would love it if grades were like our 5th vital sign, and we really use that as an indicator of wellness for kids. We're obviously not there yet, and there's a lot of system integration that would need to happen for that to be in place. But I think it would be a great vision that we should work for.
Well, thank you so much, Rebecca. Thank you so much to your team. We look forward to being updated in the progress of your research. We'd also like to thank you so much your commentators, Mary Jane and Joshua, for joining us. And we also want to thank everyone who joined us today's webinar. We do invite you to take a look at our upcoming webinars. Today's webinar presentation will be available for download from our archive at the Systems for Action website, so we do invite you. And if you had any questions that we weren't able to get to, or to the presenters or commentators, please do either you can forward the question to us and we can forward it to them, or you can also contact them directly and also look for more updates from their webpage too as well. So with that, I'd like to thank everyone who joined us today, and we wish you a good day and hope to see you next time.